Good afternoon. Welcome to the third session of Mini Medical School, The Heart of Health. My name is Lingyi Chen. I'm a professor of medicine with tenure in the cardiovascular division at the University of Minnesota Medical School and a board-certified cardiologist and cardiac electrophysiologist. I am also the director of the Lilley Heart Institute, a research institute whose mission is to discover novel strategies to promote cardiovascular health and reduce suffering from cardiovascular disease. Today, we are excited to have you here, and we look forward to sharing our final topic in the series, innovation and the future of heart care. We will begin with a moderated discussion followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and it will be available later this week on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. Today, we have the privilege of speaking with a panel of leading experts in cardiovascular care at the University of Minnesota on groundbreaking innovations shaping the future of cardiovascular care. And now, to introduce our panelists, I will first bring in Dr. David Bandit. Dr. Bandit is a professor of medicine with tenure in the cardiovascular division at the University of Minnesota Medical School, where he established the Cardiac Arrhythmia and Syncope Center. Working with colleagues of various disciplines, he helped foster what has become a very active and highly successful research program in resuscitation science. His principal research interests focus on understanding fainting and sudden collapses, as well as developing better ways to perform CPR to protect the brain and improve recovery. So, David, can you discuss electronic heart devices and cardiovascular disease?
Well, thank you, Lingyi. Very kind of you to invite me to participate. And I welcome everybody this evening. Hopefully this will be a useful presentation giving you some insights on cardiac implantable electronic devices. Next slide, please. My disclosures are predominantly some consultant work with Medtronic, otherwise nothing relative to this presentation. Next slide. First, we should start with an overview of devices that get implanted in the body to try and correct one or other arrhythmia disturbances. Probably many people in this audience would know that about 2/3 of all of these devices are companies that manufacture them, at least, are headquartered in Minnesota. And many of the research advances that have been made here in various research laboratories around the Twin Cities area. And in fact, we have an international group of people who contribute to this research and to advances in implantable devices. The first implantable device most people know about is a pacemaker. Pacemakers initially started to be implanted in people in about the late 1950s, and at that time, the size of the devices were about equivalent to a hockey puck, and the battery drainage was such that they lasted only a few days to a few months, but nonetheless were life-saving for the people that needed them. As you can see in this image, the pacemaker is implanted under the collarbone, and there's one or two or sometimes even 3 wires that go into a vein that's colored in blue there under the collarbone, so you don't see the wires, and the device, the pacemaker itself, is under the skin. Usually there's some fat there, so we can hide it pretty well. The wires go down to the heart into various positions, usually the lower chamber, pumping chamber on the right side, the right atrium, and occasionally through a special vein over towards the left ventricle. We have, over the years, become more and more advanced in the placement of these wires, and we can accomplish much more than we used to with a regular pacemaker in the 50s and 60s and 70s. Next slide, please. The location of the pacemaker, usually you can see it as just a little bump in a patient. It's pretty well hidden because they're rather thin, probably no more than half a centimeter thick. And as you can see, this gentleman on the left had a pacemaker installed. You can see the small incision, it's healing. And in most people, it will heal up very nicely and just be a little white line. On the right-hand side of the screen, you can see an X-ray. Somebody's pointing at the pacemaker, which is located, again, buried under the skin, so it can't be seen from the outside. And you can see the wires run up, straight up to the top, and then down through that vein that I described earlier to the heart itself. And then they enter on the inside of the heart. And these days, there are very small little screws on the end of the wires to keep them stable in position. Next slide. Leadless pacemakers have now been advanced into care of patients as well. That means no wires. They're put in through a large vein in the leg. You can see on the far left, the large vein goes up towards the heart, and the device is then positioned inside the right ventricle. You can see that's in the screen that shows the arrows. And then as we move to the right across this image, you can see the device is hooked in. There's still a wire that's attached to the back, so we haven't released it yet. We want to make sure it's securely in position. Then that wire detaches, and the pacemaker, which is able to do all the things that a regular pacemaker can do, sits inside the heart free. But of course, it can't go anywhere because it's attached down by some very fine suture-like metal pieces that keep it nice and stable and steady in there. Next slide, please. Pacemakers nowadays typically last about 12, 13 years. In the early days, shown on this graph, you can see on the y-axis, survival. That's survival of the device, I should say, not the patient. And then years are on the abscissa, the x-axis. And in the early devices, shown by solid lines towards the left, they lasted at most, sometimes, well, I said earlier, a few months, but then the batteries got better, and they last, 5, 6 years. Nowadays, with lithium batteries, you can see at the top, we have longevities that are out 10, 12, 13 years. There was at a time that we had nuclear-powered pacemakers, but the nuclear disposal became quite a limitation, and consequently, those are no longer commercially available. But lithium provides a power source that gives almost, I wouldn't say equivalent longevity, but certainly adequate longevity. Next slide. In addition to pacemakers, in the recent years, we've developed devices, implantable defibrillators. These are devices that can actually provide shock, whereas a pacemaker is used to treat slow heart rhythms. Defibrillators are used to treat life-threatening fast heart rhythms. In the image shown at the bottom of this slide, you can see, starting from the left, something labeled VT, that's a bad fast rhythm. In the middle of that ECG strip, you see a big shock has been delivered. And on the right-hand side, you can see that a more regular, normal-looking rhythm has been restored. The ability to provide enough energy to deliver a shock that would stop a bad heart rhythm was quite an advance. Took many, many years to develop, and now is an everyday thing. And the devices, I don't know whether you'll be able to tell, but you look at my hand, and you can see this is a typical defibrillator. Pretty small, not much bigger than a pacemaker in reality. Next slide. In the case of defibrillators, We put them under the skin, just like a pacemaker. That's shown in the image on your left. And on the right, we now have some defibrillators that are not requiring any wires in the blood vessels at all. They sit under the skin, and the wiring is sufficient to provide a shock that's equivalent to if the wire had been inside the heart itself. So this is another substantial advance, very good for people who are young, where you don't want to put too much wiring into the blood vessels at an early age, because that might tend to block the blood vessel up. So putting it subcutaneously to provide the protection that a device like a defibrillator provides is a big step forward in the treatment of individuals who need such a protection. Next slide. The ICD, or the implantable cardiac defibrillator, has been quite effective in preventing sudden deaths. And in this slide, you can see that in the dashed line, I'm looking, by the way, at prevention, the proportion of people who died suddenly is shown on the y-axis, and on the horizontal axis at the bottom are years of longevity. And you can see that the very best medical therapy that we have, shown by the dashed line, that's a drug called amiodarone and another one called metoprolol used in combination, provided some protection over time for these patients. But the solid line at the top is what happened if you put a defibrillator in. Much better protection. And I think the longevity of these patients now is well proven in multiple studies. Next slide. In addition to just conventional pacing, I mentioned earlier that sometimes we have to put in a third wire. This third wire goes into a special vein in the heart. If one looks at the image on the left, you'll see that we have indicated there a wire that goes to the right atrium from the pacemaker that's under the collarbone, and another wire in the right ventricle. But in addition to that, shown in the right-hand image, there's a third wire that goes into a large vein, a special vein that drains into the right atrium. It can be sometimes tricky to get into that vein, but it's proven to be very valuable because that vein runs along to the left ventricle on the outside of the left ventricle. We don't want to put anything in the left ventricle if we can avoid it. And outside the left ventricle, by pacing, it helps to improve the contraction of the heart as a whole, all three of those leads working together. And that's been very helpful in reducing some of the symptoms associated with heart failure with reduced heart function, and is now a fairly standard technique to help the heart failure doctors in their quest to improve heart failure symptoms. The device is very similar to a conventional defibrillator or pacemaker. It can be either. Many of these patients with poor heart function require what we call a resynchronization defibrillator. That's where the term CRT, cardiac resynchronization therapy, comes from. And it can be either a pacemaker or defibrillator, depending on the patient's particular circumstances. Next slide. The CRT pacemaker defibrillator is schematically shown here. The CRT wire, you can see at the top, it runs through the right atrium, which is not labeled, but it's at the top on the left there. And then into that special vein, which is labeled CS. You can barely see it, small letters. Coronary sinus is what it stands for. And then over the top of the left ventricle. The other leads that are shown are the conventional ventricular leads, and they can go in any of several places in the right ventricle. It just together provides a more physiologic contraction to the heart, and in sick hearts gives a little bit more benefit for the cardiac output, the amount of blood that is generated on each heartbeat. Next slide. There are other types of implanted devices that are sort of devised to do other things other than pace the heart or defibrillate the heart. One of the most widely used is actually an implantable heart monitor. One time, years ago, all we had to detect an abnormal heart rhythm in a patient would be a device that might record for 24 hours or even less. Subsequently, we developed heart monitors that you could wear for diagnostic purposes that would last a week or two. But now we have very small devices, like the device labeled on the as Reveal Link on the left. Various companies manufacture them, so this isn't the only one available. They're quite tiny, and they slip under the skin, and they have batteries that can last 3 to 4 years. So for people that have very infrequent or hard to diagnose heart rhythm disorders, one can slip this under the skin and make a recording on a daily basis for many years. And eventually, this has proved to be highly successful in diagnosing what otherwise would be almost impossible to detect heart rhythm disturbances. So these are widely used, and they can be removed, of course, when they've accomplished their goal. Next slide. The implanted heart monitor, you can see, is shown in an image at the left there. It's rather tiny, so it doesn't really make much of an impact as far as the patient's sense of aesthetics is concerned. It can be really hidden, and the scar that goes along with it is probably half a centimeter or less in width and generally heals up, so you can often hardly see it when you go back to try to remove the device 3 or 4 years later. Next slide. And just to move on to the last implanted device I'll discuss, this is perhaps the most recent advance that we've seen. And this is a pacemaker-like device. It stimulates the heart, but it stimulates with very, very low energy. So it doesn't cause the heart per se to contract, but it causes some change in the biochemistry of the heart cells. And the biochemistry is the key to the contraction properties of the muscle. And in particular, release of calcium into the cells helps to power each cell to create a contraction. And the low energy delivered here has the benefit of providing additional calcium that's circulating around but not being used, pushing them into the cells and causing even a sick cell to maybe contract a little stronger. And thus, the heart itself sees some improvement in overall contraction capability. So again, a tool using electricity to try to help in the heart failure or diminished heart function category. This is relatively new, but has had some very nice studies. It can be, of course, used in conjunction with defibrillators that are implanted or pacemakers that are implanted. So you can imagine a patient might have several such devices, pacemaker, defibrillator together, and one of these contractility modulation devices in place. So overall, this is another frontier that is being explored in trying to use electricity to improve cardiac function. Next slide. Cardiac contractility modulation is the term that's used, and I won't go into the details, but basically, as I said earlier, it doesn't cause the whole heart to contract because the energy is low, but it causes a change in the local biochemistry milieu so that the heart cells contract more powerfully. Even sick heart cells can be improved to some extent. Next slide. So in summary, there are a number of devices that use electricity. We call them implantable electrical devices, cardiac implantable electrical devices. Pacemakers were number one, and they led the way. Implantable defibrillators were a very important advent. The defibrillator really became part of the landscape for us in the mid-1980s. Insertable cardiac monitors came available in the early 1990s. And now in the 2020s, we're seeing cardiac contractility, and hopefully we'll see other advances using electricity to help physicians improve the quality of life of patients. Thank you very much for your attention.
Thank you, David. And now I would like to introduce Dr. Konstantin Alifaris. Dr. Alifaris is the director of the Institute for Health Informatics. He has a Master of Science, a PhD degree, and a postdoctoral training in artificial intelligence. As a faculty member over the course of 25 years, he has taught AI, and he and his team have created novel AI methods and applied it in a variety of biomedical domains. His research focuses on using AI to turn complex medical information into useful discoveries in the form of predictive and diagnostic tests, new drugs, and improving healthcare quality and reducing costs, as well as enabling personalized treatments tailored to individual patients. So, Konstantin, can you discuss the application of artificial intelligence in cardiovascular care?
Thank you, Dr. Chen. It's a real pleasure to join this distinguished panel and our audience, the community that we're serving at the University of Minnesota. Artificial intelligence is a very exciting area of technology that has captured the imagination of both the scientific community as well as the general public. The next slide, please. Let me first state that I have no conflict of interest to report, no financial relationships to disclose, and will not discuss off-label use or investigational use. I do receive, myself and my team, NIH funding to conduct research for NIH peer-reviewed projects. So in this brief introduction to this topic, we will first cover some basic concepts. Let's move. Thank you. A few basic concepts to help us share a common vocabulary on biomedical artificial intelligence. And then we will discuss a few example applications in the areas of cardiovascular diagnosis, prognosis and risk evaluation, discovery of new cardiovascular treatments, personalizing treatment choices to the needs and characteristics of individual patients, and of course also dealing with the health and function of the whole system of care through studies that try to optimize the health economics by reducing cost, increasing efficiency, and so forth. The next, please. So let's start with a few basic concepts. Artificial intelligence, or AI for short, is the science and technology that creates and studies computer systems that are of a very special kind. Systems that can perform intelligent behavior, for example, representing knowledge, reasoning with this knowledge, learning, understanding human language and other types of languages, planning, and so forth. There are many forms of AI that include machine learning, knowledge representation, logic-based reasoning, planning, natural language processing, causal artificial intelligence, predictive artificial intelligence, generative artificial intelligence, and many more. The next, please. Of great value and particular relevance to biomedical and health applications is machine learning. This is the specific branch of AI that deals with computer systems that learn how to solve problems by analyzing examples of problems and their solutions. Often, one may hear about machine learning algorithms. These are generalized computer programs that once they're translated by a professional programmer in some computer programming language, they can analyze data to learn how to solve related problems. And finally, machine learning models is the output of machine learning algorithms when they run on data. The models themselves, when they are given inputs describing, for example, a patient's problem, they output the solution to that problem case. The next, please. So let's see how this works from a high-level perspective. let's consider the example of a highly idealized and simplified vignette, obviously, but still useful for our purposes. So consider a cardiologist who wishes to use AI to answer the question of who of her patients is at high risk for a heart attack on the basis of routinely collected demographic and clinical data. In such an example, a common workflow may involve that the cardiologist will partner with an AI scientist, and together they will first collect data from many patients observed over long periods of time. Then the AI expert would implement several machine learning algorithms, for example, deep learning, decision trees, support vector machines, boosting, or other algorithm families. Then they would run these programs, these machine learning algorithm implementations on the data. The algorithms will produce models attempting to solve this problem. In the next phase, the models will be evaluated and the most accurate model or models will be selected. Then typically appropriate regulatory approvals are obtained to ensure safety and effectiveness. And finally, the model will be used in the form of a decision support tool, which in our days is most typically incorporated in the electronic health record, supporting the efficient management of the future patients. So that gives you a sense of how these concepts are being brought together in tandem and in harmony to achieve general clinical goals through machine learning methodologies. The next, please. Now, I want to emphasize that in AI, especially healthcare-related and clinical AI, and with clinical AI, we mean AI that affects clinical decisions about patients and therefore has the potential to help the patient's outcomes, and also has the potential, if the AI is not designed correctly or implemented correctly or monitored correctly, it has the potential to also cause harm. So clinical AI, it can be a very beneficial technology when designed and executed correctly. And it is very important in the life cycle of creating and deploying clinical AI systems and tests and modalities and decision support tools to engage many constituents along the way. And these constituents are first, of course, the patients, then the clinical teams that care for these patients, the AI computer scientists and data scientists and engineers, very importantly, ethics experts that will work with the other constituents to ensure that the design and application of the AI technology is equitable and does not violate any ethical principles and rights of patients. Then health system administrators, that they have to align the management and design of the healthcare systems accordingly. Payers who have to pay for the cost of these technologies. And of course, regulating bodies, regulators and legal compliance experts that will ensure that laws are followed and that appropriate oversight has been exercised for cost and effectiveness. The next, please. So I hope this very short introduction has given the audience today an initial understanding of some very fundamental concepts, because sometimes there are misconceptions and misunderstandings of these foundational concepts. So I hope that we have a common language now, and you have a common language to read the literature, read the news, educate yourselves in the future through self-study, and of course consulting with your cardiologists and others who are part of the healthcare system and your communities and so forth. So let's see now a few examples of how these concepts are being brought to cutting-edge research and subsequent healthcare application. So the first example is AI for accurate cardiovascular diagnosis. So this particular research work addressed the problem of accurately diagnosing myocardial infarction, also known as a heart attack. And heart attack is a condition where typically through blockage of the arteries that provide the blood supply to the heart muscle itself, because of this blockage, the heart muscle may suffer damage, the heart may not work properly, and it may be also a life-threatening condition. So it's very important for patients who suffer initial stages or later stages of heart attack that an accurate diagnosis is established as fast as possible, because cardiologists have at their disposal today a number of very effective treatments in their hands to ensure that early diagnosis translates into early treatment that can save lives with a very high probability of success if the diagnosis is accurate and early on. So the problem here is how to achieve this. And one of the main tools in today's medicine for diagnosing a heart attack is the blood levels of troponin, which is a protein that comes from the heart muscle. So if the heart muscle is injured, for example, because of heart attack, then troponin is released at high levels in the bloodstream. It can be easily tested, and if it exceeds a particular threshold, then it means that there is, with corresponding probability, a diagnosis of heart attack. Now, typical diagnostic procedures and standards of care do not involve all the factors that may affect, though, the concentration of this important molecule. And therefore, this study sought to collect data from 10,000 or so patients and analyze the troponin levels together with additional features, clinical features, demographics, other diseases that may happen concurrently, and come up with machine learning models that would provide a more accurate diagnosis. And indeed, such models were produced in this study, and they were tested in a very significant number of patient data, another 10,000 plus patient data. And it was established that a very, very high model, with very high degree of accuracy, measured in something called the area under the curve, which basically 100% or 1 means perfect diagnosis, and 50% or 0.5 means the equivalent of flipping a random coin. So this test achieved a 0.95 or 95% area under the curve, which is like an outstanding level of diagnostic performance. Therefore, this opens the road for using such this or similar clinical decision support AI systems to make sure that accurate diagnoses have been made. The patients who suffer from a heart attack receive early treatment. Those who do not have heart attack are routed for less intensive management approaches. The next one, please. So this second example is not about diagnosis. Diagnosis means finding out what's the current condition, the current disease or state that the patient is in. Prognosis means trying to predict what's going to happen in the future, either under normal conditions or after some treatment in terms of what will be the long-term response to treatment and so forth. So this task is prognosis and risk evaluation, and this particular example study using machine learning attempted to create machine learning models to provide aggregate estimates of cardiovascular disease using a very large sample of patients with 423,000 plus participants from something called the UK Biobank, which is a vast database of medical records from the United Kingdom's national health system, the NHS, and using hundreds of variables, these investigators build models that were able to advance the state of the art for this kind of prognostic and risk evaluation task by 5 points AUC, which may not seem as extraordinarily high, but it's a substantial improvement over the current state of the art that can make a clinical difference. The next one, please. So this example is about discovery of new treatments. And this work is work we have been doing at the University of Minnesota with our colleagues at Duke University. And the goal here is to find ways to improve cardiovascular disease risk by targeting molecules responsible for this. And specifically, the question is, we know that diet and exercise have beneficial cardiovascular effects. We know that they reduce the risk for heart attack, for heart failure, for stroke, etc. And the question is, what is happening on a biological, cellular, and molecular level to people who are exercising and they are undergoing diet, caloric restriction, and other forms of diet? So the goal here is if we can find the molecular chain of events from diet and exercise all the way to actual processes that we know they are associated with lower cardiometabolic risk, such as insulin resistance, for example, then we can target these molecules with specific drugs and therefore achieve one or of two things. One is to achieve the same effect that diet and exercise have without the diet and the exercise for those who cannot exercise regularly for a variety of medical or other reasons, and also to augment the effects of diet and exercise. So this is a very exciting project that represents the kind of future drug discovery that is totally enabled and dependent on causal AI. That's specifically the type of AI that can learn these causal chains of molecular events. The next one, and then the one after that. Thank you. This next project, example of the application of AI for advancing cardiovascular healthcare and health, is tailoring statin choices to individuals. And this is a form of personalized medicine. Personalized medicine means that we don't treat all patients the same, that we will give different drugs or different dosages or make adjustments of treatments for the individual characteristics and needs of patients, of individual patients. So these researchers here, they dealt with the problem of personalized treatment of statins. And statins is a class of drugs which are very highly effective in lowering low-density lipoprotein cholesterol, which, when lowered, prevents atherosclerotic cardiovascular disease and substantially reduces all-cause mortality. Now, statins are very effective. They're relatively cheap. The problem is that they have some adverse effects sometimes that make some patients stop taking them. So it's estimated that 50% of patients prescribed with statins do not get these great benefits by this class of drugs because they discontinue because of adverse events. And then their clinicians, their clinical care team, their cardiologists will adjust the statin choice or level, trying to mitigate this. This project is has used machine learning to try to do preemptively this choice of the right statin type and level for each individual patient separately in order to increase adherence to this important medication. And it used a vast data set called the Optum Labs Data Warehouse, which includes medical and pharmacy claims, laboratory results, and other data, over 130 million patients. So it's a vast data set that has tremendous variety and sample size. And the next and final one, please. So the last example here of the application of AI for improving cardiovascular health has to do with health economics. As you know, our country, the United States, has an incredibly powerful health system. It adopts the most sophisticated and technologically advanced medicine anywhere. At the same time, it's very expensive. And because it's very expensive, sometimes not everybody who needs the care does not get it. Therefore, it's imperative not only to improve the technology and the effectiveness of devices, drugs, management regimes, and so forth, but also to make it affordable, cheaper, less costly. And this study used machine learning to essentially predict preventable hospitalization, preventable emergency department visits, and other types of preventable costs with the intent to basically route patients who don't need these extremely costly interventions away and route the patients who need them toward these costly interventions, thereby reducing the overall healthcare cost of the system. So that's the last example that I want to present today. Next slide, please. If you want to learn more about health AI, more in depth, my colleagues at the University of Minnesota and I put together a book called Artificial Intelligence and Machine Learning in Healthcare and Medical Sciences. This is published by the scientific publishing house of Springer. It's the first one that deals explicitly with best practices and pitfalls, and you can download it for free. It's open access. Open access means that anybody can download it without paying anything. It's a public service, and I would welcome your going to this link here or Googling Simon and Aliferis Artificial Intelligence, finding the website, downloading this, because it has a wealth of information, a vast majority of which is written in a way that can be accessed by the general public. It doesn't need for someone to have in-depth training in computer science, math, and all that. So thank you for the opportunity to discuss these exciting developments with you. I look forward to answering your questions.
Thank you, Konstantin. Now, it is my pleasure to bring in Dr. Thomas Alexy. Dr. Alexy is an associate professor of medicine in the cardiovascular division at the University of Minnesota Medical School, as well as the medical director of the heart transplant program. He's a clinical research scholar and has dedicated his work to improving outcomes for patients with advanced heart failure. Thomas, can you discuss heart transplantation?
Absolutely. Thank you so much, Lindy, for having me here and being part of this amazing panel and talk a little bit about transplantation. I will try to share my screen. Hopefully you can see this by now. Again, thank you for the opportunity. And yes, just for the disclosures, I do not have any relevant disclosures to this program and presentation. However, one disclosure that is important and I wanted to emphasize, I will show some actual videos from heart transplantations and hearts that are actually were taken during our surgeries and actual images. So hopefully that is okay. If not, I will warn everyone in advance that those are coming up. So what I thought to talk a little bit about is to discuss what is heart transplantation? Has it been around for a long time? Who may benefit from the transplant? How commonly we are doing this? Just briefly show how it is performed. And this is where I will show a few videos just to demonstrate what we do. We'll show why we are doing this, and that would include how long the recipient survive and what potential complications they may have during the procedure, or more importantly, after the surgery is completed. So what is heart transplantation and how new this surgical technique or procedure is? So heart transplantation is really when we have, and I will show it a little bit more detail, but where we have a person, that we call them a donor, who is offering their organs after they become brain dead by law, so they cannot make their decisions, cannot recover by any means. And the family decides, or the donor decided that they will offer their organs and surgically remove the selected organs or offered organs, and we will match it with the potential recipient who medically would benefit the most from the transplantation, potentially saving the life of many people and many recipients, which would include not only the heart, just emphasizing also the lungs, the liver, intestines, pancreas, kidney. So many other organs can be offered, and one potential donor, again, who is very generous and offers their organs, can save the lives of many, many very sick patients. Something which is very relevant to the University of Minnesota, and I think we are very, very proud of this fact. Dr. Norman Shumway was actually a very important pioneer of heart transplantation, and he was performing these surgeries in dogs and actually perfected the surgery. And Christian Bernard, who was actually one of his trainees, performed the first heart transplantation in Cape Town in South Africa in 1967. So this tells you that this is not entirely new technique or a surgical procedure. It's been around since 1967. Why in Cape Town? Primarily because there were some different regulations about brain death and how these surgeries could be performed. So this is why it was done there. However, Dr. Shumway actually performed the fourth heart transplantation in the world, as you can see, just roughly a month later here in the United States. And to date, there's been more than 100,000 such surgeries performed. So that means more than 100,000 lives have been saved during with heart transplantation. So what is this process? Just to explain a little bit in more detail, and this is actually an image that was taken of an actual heart transplant recipient at the University of Minnesota. So essentially, we have a very sick patient, as you can see here. These patients are typically in the intensive care unit, so they require machines to support their heart, because otherwise the heart is too weak for the patient to stay alive. Unfortunately, often these patients, as you can see here too, require other machines too. For example, dialysis to keep the blood clean and replacing the kidney function. Often they are on the breathing machine, essentially to provide respirations and breathing for this patient. So, of course, these patients are in a medically induced coma. Most of them won't necessarily remember everything that's been happening during this very difficult time, but these patients are really sick. They undergo a very thorough evaluation by a very big team. It's typically consists about 30 to 40 members, from cardiologists to surgeons to social worker, dietitian, everyone essentially you can imagine that can be important for the surgery and recovery. And then if the potential recipient is considered to be eligible and a good potential candidate, then we will place them on the heart transplant waiting list. Now, things change a lot around this, and if there's any specific question, I'm happy to go into details, but this would be way too long. But oftentimes patients wait quite a bit to get their life-saving operation, which can go, unfortunately, these days up to several months, 5-6 months. People spend in the ICU on life support just to get the life-saving organ. Finally, when that call comes, this can happen any time of the day or the year. We are on call 24/7 to receive organ offers. We call when a potential donor person is identified, then they undergo similar evaluation, look at different organs. We look at the heart, of course, and these organs are typically offered from donors who are considered brain dead. So again, there's no chance for recovery for these patients. Some unfortunate event could have happened. It could have been accident or many other things. Usually the family consents to organ donation, and it's, again, does not necessarily just involve the heart, but every other organ can be donated. Once all the preparations are made, the surgeons travel to the recipient, to the donor, and they surgically remove the organs, and they transport the heart, in our case, back to the potential recipient. And we remove the recipient heart at the time when the organ actually arrives to the operating theater, and then the patient undergoes the donor heart implantation. The whole procedure takes about 8 hours, as I try to show a little bit on that figure. So several sutures and several cuts are made. Typically these surgeries, and I'm not trying to say it's not a complicated surgery, but it's relatively big structure the surgeons deal with. So it's a little bit less technically demanding than, for example, a bypass surgery. However, of course, it is a heart transplantation, so it's a massive surgery and a very big deal for the patients. Just to give you a little idea, who are those patients who might benefit from heart transplantation? And I'm just giving you a few examples. Of course, I can't go through all the list who would benefit. But most of the patients, and the vast majority, will have a very weak heart. And this can be from several reasons. About 50% of our recipients will have a heart attack, which we just heard a little bit about. And it means that a big part of their heart, essentially, the muscle dies and unable to function. So the heart will be very weak. Sometimes these patients could have an infection that affected the heart. They could have a genetic condition that they were born with, and usually these patients are on the younger age, or sometimes certain toxins, even medications, can lead to a very weak heart, so that these patients need transplantation. Oftentimes, we support our patients with a durable LVAD, and without going into the details, that this is essentially a heart pump that patients can go home with, spend a couple of years with their family, get on the heart transplant list, and then undergo heart transplantation. They can have serious arrhythmias, heart rhythm problems. Dr. Bandit told a little bit about this earlier. They could have severe chest pain that we are unable to manage, and the only way to solve their pain and exercise tolerance is really just to proceed with the transplantation. And increasingly, we see patients who have born the certain heart complications and heart problems that they were born with. For example, just one ventricle instead of the two ventricles, and so on. And really, these structural problems can only be fixed with a heart transplantation rather than undergoing further surgeries. One of the critical question that we always look at for our potential recipient, who are the patients that are not great candidates for heart transplantation, because this is sometimes very hard, but we need to make very difficult decisions. And typically, just again to give you a few examples, age above 72 would be prohibitive. Patients with a BMI of 38 or above, because their recovery and rehabilitation can get very difficult. Patients who are smoking actively, using alcohol or illicit drugs, because we need to protect the graft and the gift that they receive with the transplantation. And similar goes for the compliance. If they don't take medications after the transplant, that could be deadly. So it's very important that they are very compliant. If they have a recent stroke, which is disabling, or serious lung problems that would prevent them coming off the breathing machines after the surgery, or if they have cancer or have had cancer in the recent 1 to 5 years, depending on the type of the cancer, could be prohibitive for transplantation. So how common it is, and just to show you where we have come from the experiments and the first transplants done by Dr. Shambay. Currently in the United States, this is very recent data, there are 159 active heart transplant programs. These are all performing a various number of transplants. And just to show you how the number of transplants have changed in the initial surgeries, there's been a significant growth initially, and then it kind of leveled out until the mid-2010s. And the past couple of years, 5 to 8 years, there's been again a significant growth. There are several factors to this. Unfortunate opioid epidemic contributed to this in the United States, but other advancements too. For example, in technology, I will show you a few that affected how we can procure and transport some of these organs to their recipients. So luckily, the number of available hearts for transplantation increases and the number of surgeries increases. Unfortunately, we are still very far from being able to serve all our sick patients and transplant all our sick patients. So more and more transplantation will be needed. So we are always looking for technologies and opportunities to increase our numbers in the future. Where is the University of Minnesota? In this, with these numbers, we have performed in 2023 a total of 42 heart transplantations. We were number 34 in the country. I will show you in just a little bit what is our limitation mainly, but this actually represents an increase over the past couple of years. So how is the transplantation done? And this is where I will show you a few videos. Again, I apologize in advance. Hopefully that is okay. So again, we identify the donor. As I mentioned, the surgeons travel to the donor hospital. Usually we use planes to travel due to the distance and the time it's required. Open the chest for the potential donor, and we actually evaluate the heart in the body of the donor. We do a lot of work ahead, ultrasounds, echocardiogram, sometimes catheterizations to make sure this is the perfect organ. But the visualization is very, very important before proceeding with surgery. After this, the surgeons stop the heart and they surgically remove it. As you can see, they are removing the structures. It's very important how and where you cut the vessels. This is one of the vessels they are cutting right now. And ultimately, they remove the heart from the donor. Subsequently, there's multiple ways to transport the organs. Traditionally, and for 40 years, we've been transporting these grafts or hearts on ice in a box that you can see. So it's a very non-descriptive box. We get on the plane again and bring the hearts back to the recipient, who by this time will be in the operating room and getting prepared for the surgery. Now, when the heart arrives, the implanting surgeons take another look at the heart, make sure everything looks good from the valves standpoint. There's no injuries to the heart muscle. And this is the part which takes about an hour or so when they take the big vessels. As you can see right there, that is one of the vessels that they are suturing together and essentially go through all the main structures to suture the heart. And it takes about an hour or so to perform. And ultimately, as you can see, this is the end of the surgery. That's the blue is a pacemaker wire that you can see what Dr. Bendit was describing earlier. This is real life when we are pacing the heart, and you see it's functioning normally. So this recipient did very well, and we were able to save his life. No more video. Well, I'll show one more video soon. So I mentioned we are a little bit limited in Minnesota, and I just draw some circles. We have time limitations, how far we can travel to obtain and recover these hearts. Usually we like to stay within 500 miles just because that takes about an hour and a half with the plane to deliver. And 1,000 miles is getting to the outer boundaries. It takes about 2 hours, a little bit over 2 hours to transport the hearts. And we really would like to get the hearts within 2 hours. Ideally more hour and a half travel time. So as you can see, Chicago is within the 500 miles, but many of the other areas, especially west of us, North Dakota, South Dakota, is really the population density is lower. So this limits, unfortunately, a little bit our donor availability. So we are always looking at options and opportunities how to travel further and how to recover hearts from a further distance. One of these is, rather than transporting the heart in a box, is this novel device, this Sherpa pack. It is essentially a very temperature-controlled container As you can see on this illustration, we place the heart in the middle, and it maintains the heart in a very good condition and makes it possible to travel with the heart a little bit longer. This is where I will show you just another video. This is another technology which is called machine perfusion. This is when we take the donor heart and put the heart on this machine. And with this machine, we are able to transport the organ a little bit longer. The novelty of this device is that the heart is perfused by the donor's own blood. And as you can see, it's actually beating during the transport process. And I'll show you another video. This is just before implantation. This video was taken actually in our operating room just before taking the organ and implanting to the recipient. So with this, we were really successful extending the distance, and this is just one method how we can recover organs from further distance. And now really no more videos. Why we do this? Just last 2 slides, just to show you very quickly. Again, just to save a patient's life and improve their quality of life. Those patients that I mentioned typically would live less than a year or 2 years. As you can see, the survival is less than 2 years, less than 8% at 2 years, and definitely less than 2% at 3 years if we were not be able to proceed with the heart transplantation. Now, this is a fairly updated data. You can see that if patients undergo the heart transplantation, they live about 12 years median, so half of the patients will reach 12 years or longer. We actually have patients who live 40 years with their heart transplantation. So there's definitely a big plus over the 24% survival at 1 year. So this is really life-saving. These patients can have families, they travel, they enjoy sports, they go out golfing, they do daily activities just like we do. Most of the time, you wouldn't even know that they actually had the heart transplantation. Last slide. We have to emphasize that there are some complications, and we have to monitor heart recipients very closely. Some of these I just mentioned here. Of course, we can have problems with the heart immediately after the transplantation, where we have difficulties restarting the heart. So we can support these patients with something called an ECMO or heart-lung machine. Of course, the recipient's body recognizes that this is a heart which is coming from a different individual. So these patients will need to be on immunosuppressive agents, so something that prevents rejection of this organ. They can have irregular heart rhythms. The risk of infections goes up significantly, just again because we are tempering down their own immune system that fights infection. They can develop coronary disease, kidney, liver disease, and unfortunately cancers on the long run. But again, we have patients who lived 40 years. Actually, we have patients who climbed Mount Everest recently. So these are the really great success stories that we are very proud of and be here, help our patients. So again, it improves survival for selected patients, critical the matching, and we need further research in the area, how we can provide heart transplantation to more patients, because we know there's a lot more potential recipients out there that we need to help in the near future. And with that, I would like to thank all of you and hope the videos were acceptable, and happy to take any questions around this. I will stop sharing.
All right, great. Thank you, David, Konstantin, and Thomas. Now we will move on to the questions submitted by our participants. As a reminder, you can submit your questions to our panelists using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. And now I'll start with a few questions. And the first question is for David. Are lithium batteries in cardiac devices safe?
Oh, this is a very good question. Well, the good news is that we don't pack pacemaker patients into the cargo hold. So they travel with us, and lithium batteries are permitted on airplanes. They have proven to be very, very safe. But the question is a reasonable question because we've had a lot of concern about lithium batteries. We're not allowed to put them in the cargo hold on planes, but we are carrying them on as patients. So the simple answer is very safe. Nobody's, to my knowledge, ever reported a problem with them.
Okay, great. Thank you, David. And the second question will go to Konstantin. Currently, do cardiologists use AI to diagnose cardiac diseases on a regular basis, or is it only experimental right now? And is it covered by insurance?
So I think that the best person to answer this question, Lin Yi, is you by leading clinical cardiological teams and being right in the midst of it. I can only provide a general comment, and maybe then you can augment Lin Yi from current clinical practice. Generally, clinical AI is not translated in everyday clinical practice. There are very few exceptions to this. Example exceptions are, for example, when you have automated image processing that analyzes an EKG and it's part of the machine that does the EKG. Also, some automated diagnostic image processing embedded in sonograms and other imaging devices that are assistive for radiologists. Also, there is a small number of oncological molecular profile-based tests that determine which patient should get what drug or whether a patient should get a particular drug. For example, de-explain in breast cancer and other similar molecular profiles. And the vast majority of AI either exists in the research space with hundreds of thousands of papers. For example, oncology has been revolutionized by using machine learning methods because it has become an integral part of discovery of targeted treatments, which, as we know, have increased the outcomes in cancer tremendously. The other part of the literature and the current studies is preclinical. Is preclinical, which means that there are feasibility studies, there are proof of concept studies, there are animal model studies, and there are some very early stage human subject studies. But we don't have yet a wholesale end-to-end incorporation of clinically mature, certified for effectiveness and safety incorporation of AI. And part of this, if you allow me, Lin Yi, to say, of the effort is to make this, to bridge this situation, to bridge the gap from the research domain into the clinical benefit domain. And that's why we recently launched at the University of Minnesota a collaborative called Atria that is specifically targeting AI and cardiovascular disease with the ultimate intent to bridge this gap. Lin Yi, please comment more on any other kind of clinically widely used AI in your experience.
Yeah, thank you, Konstantin. I agree with everything you said. I just want to add, yes, there's currently the need to bridge the gap between the evidence and the research that have been published and also implementing it into practice. And that's the reason why Konstantin, you and I have launched this new program, Atria. So more to come, and we're excited about the work that we'll be doing. Now, I would like to turn to Thomas. Thomas, what kinds of innovations or research on the horizon are you most excited about in heart transplantation today?
Yeah, thank you. This is a very interesting and important question. One of the major innovations and the way that we are actually going at the moment with the heart transplantation is how we are recovering the donor hearts and how we are transporting the donor heart. So just our goal is really to be able to increase the number of potential donors and transfer the organs back to the recipients. This is where multiple developments have been. The one I showed you with the beating heart, there's another newer technology which perfuses the heart with a cold solution and allows longer transportation. I think ultimately what I would like to see, and there's been unfortunately a little bit less development the past 10, 15 years, is medical management of immunosuppression. So how we reduce the activity, the recipient's immune system to attack essentially the heart. It's been very difficult to develop these new agents and new medications. There are a few on the horizon, but unfortunately, they are not in clinical practice yet. So I was actually thinking how AI could potentially help us move a little bit in this field too, but I think this will take some time.
Okay, thank you very much, Thomas. So back to David. So David, you mentioned that electronic devices can be used to help patients with heart failure. So when you say someone has heart failure, what do you exactly mean?
Well, this is a question that most people think of as being that the heart fails to pump adequately to provide sufficient perfusion to the organ systems of the body. So that's the general definition. I think even a heart failure person might agree with me. I'm an electrician, as you know. But we divide it up maybe simplistically in two parts. One is where the heart pump itself is weak and it doesn't provide enough blood on each heartbeat. And the second, which has now become recognized as very, very common, equally common as the first, is when the heart is perhaps too stiff and it doesn't fill adequately so that it's unable to pump enough on each heartbeat. The stiff heart, typically older people, but occurs with various forms of heart disease. The heart that fails to pump enough is more the target for the electrician, because we can help with that perhaps a little, but we don't help very much with the stiff heart situation yet, maybe in the future.
Great. Thank you, David. Okay, so now here's an interesting question for Constantine. Do patients know, or are there ways for patients to know that their care is being influenced by AI-based tools?
I think it depends on the tools and the specific formats that the AI is delivered in care. So, for example, if a test requires patient approval to be conducted, often because payers will not pay for that, or there is a heavy copay, then the clinical team, the clinician, will ask the patient whether they want this test performed. And that's a common situation. If the AI is embedded in some fully automated or hidden away way, for example, as part of the provider order entry system in the medical record, or as an ancillary or supportive assistive decision support tool for the clinician, the patient never sees that. Similarly, if the AI exists in the research pipeline of developing the standard of care, the patient will not see that. And that may also be invisible to the clinician herself or himself in many cases. The critical thing, I believe, is whether there is any risk from the AI, and therefore the patient has to consent to any such risk, assuming it has not been covered by regulatory approvals or other appropriate risk management steps. We don't see this happening yet in real life. And I think that in a well-managed system that enforces safety and regulatory review and approval of treatments, diagnostics, and every other major decision taking place in the process of caring for patients, that essentially this is not necessary at all, and nor is it ethically mandated, in the same way that nobody is telling the patient that their creatinine levels or their hematocrit levels, etc., were obtained by a particular biochemical protocol, reaction, reagent, or device, because once it's approved and certified and regulated for effectiveness and safety, there's no need, and it would make it impossible to actually care for patients if we bombard them with thousands and millions of disclosures about all the pieces of technology that are employed to make the care possible. There are way too many of those. It would not be possible to disclose all of them. It would also not have any real value for the patients.
Okay. Great. Thank you, Konstantin. Now, Thomas, is there an age when a donor's organs are no longer viable?
Thank you. That is a very important question, and I don't know if I can answer it with one single answer. Every single center or transplant center across the country can choose what they think is still appropriate, especially with regards to heart, and the age of the potential donor, which is acceptable, will be dependent on the organ. So for kidneys, for example, I know the kidney transplant programs will be able to accept organs from older donors than, for example, heart. Our cutoff typically is 52 years at the University of Minnesota, and that's pretty much similar across the country. I'm just trying to think if we have accepted an organ from a 52-year-old donor just because other comorbidities and other diseases often affect the heart at that point. But I would say the more typical age for a donor is somewhere between 25 and 45.
Okay. Thank you for that clarification, Thomas. All right. David, you mentioned a leadless pacemaker. Can we envision a leadless ICD in the future?
A very good question. I think the answer is yes. The main limitation right now is packing enough energy into a small enough package that it can be delivered through the blood vessels to the heart chambers and sort of screwed in there or otherwise held in place. Once the package is in there, then it could readily be, if it had enough power, available to provide defibrillation. I think, though, it's going to take some years because providing enough energy and slimming it down to a small size is quite a chore. It's going to be a challenge from a research and development perspective, but it's definitely on the list of the to-do list of all the major companies right now. So I think we'll see it probably be another 5 years, but I'm pretty confident we will have them.
Okay, excellent, David. Now, Konstantin, a lot of interest in AI and predicting disease. I think this question was asked in a different way earlier, but it's worth going over again. So you shared examples of how AI can be used to predict cardiovascular disease. How close actually are we in using that in clinical practice, and what are some of the barriers right now?
So thank you for this question. This is probably the biggest challenge facing advancing cardiovascular disease using AI, which is there is a technological gap between the research space and the clinical application space. And the obstacles to this are Number one, we don't know yet enough about the risk profiles and the properties, both theoretical and empirical, of many of the newer AI technologies in this space. Secondly, the framework for regulatory approval has only recently been augmented last year with provisions for more sophisticated AI and especially machine learning based innovations, new technologies. Third, the payers are fundamentally waiting for regulators to say that indeed this new AI test or decision support tool or other form of AI is approved for broad use in patient care before they start paying for it, which has, as we all understand, a cascading effect on broad clinical use. So there are several so-called implementation science obstacles around technology maturity, technology adoption, regulatory approval, coverage by insurance, education of clinicians, education of healthcare systems, education of patients. So it's pretty unbalanced. On one hand, you have a vast space, 250,000 research studies listed only in PubMed about various kinds of AI applications and research in health. You have millions of papers outside PubMed, but you have only a handful of clinically applied modalities. This is going to change in the future. It is estimated that we're going to have tens of thousands or even hundreds of thousands of AI models and other interventions. If you think about this, the combined space of diseases and treatments and other factors, the combinatorial space that describes the size of the AI technology clinical application is vast, but we are in the very beginning stages of making this translation possible. So I see many questions that are circling around the same issue. I tried to reply to a couple of them by typing. Some of the areas that some of the audience members have identified, they have a rich body of early literature. Some others are just beginning. So I just tried to answer a couple of them in typing.
Thank you, Konstantin. Okay, now back to you, Thomas. What criteria have to be fulfilled to find a perfect match for donor to recipient for a heart transplant?
That is a very good question, and it is a very difficult question to answer because I could go on for a very long time. Several factors really that we look at, and several matching criteria that we look at. First, we have to make sure that the size matches. So the organ that we are transplanting will match the recipient, because if it's too small, it's not going to be able to supply the body is blood needs, or if it's too big, we won't be able to feed the heart in. So that's one of the probably the number one problems that I am always facing. Second, we look at always the distance, again, which I showed you on the map, how far we have to go to retrieve the organ, because that can be prohibitive. We also look at immunology, for example. So sometimes recipients get blood transfusions or other reasons. Infections, for example, can have antibodies. That means there's certain potential donors whom they cannot accept organs from, otherwise they would reject immediately. So immunology, for example, is another such factor. One question that comes up, do we have to look at blood group? That is less important. So the blood group is not very much needed to be matched for heart transplantation specifically, because that will not affect rejection. Of course, we also look at donor recipient age and so on. So there's many factors that we look at and try to match as closely as possible. Sometimes we are limited depending on how sick the potential recipient is, but that's a critical, actually, that's a very important point for the transplantation process.
Okay, excellent, Thomas. Now, David, so a patient asks you a question. My doctor tells me that I need a pacemaker. How do I know that I should have a leadless pacemaker or a pacemaker with leads?
Well, generally speaking, the convention is to use a pacemaker with leads because that has the longer experience, and generally speaking, is well tolerated over very many years. So the leadless pacemaker is advantageous when the venous system, where you place the wiring, is maybe not adequate. A very small stature patient, like a young child, or an individual who's had a lot of previous surgery or pacemakers in the major veins of the body such that they're very narrow and unable to take a new device. So it's usually that kind of thing rather than leadless versus wired that the patient gets involved with. It's largely related to anatomy, at least at this stage of the game. In the future, that may change as the devices become easier to implant and smaller. So we will definitely see a trend towards leadless devices in the future. They may, in fact, become the standard in the next decade. But for now, it's mainly an anatomic issue that the doctor has to deal with.
Okay, excellent. Thank you, David, for clarifying. Now, Constantine, if you have to explain to a group of people who are unfamiliar with AI in healthcare, how would you explain the biggest difference that it will make in diagnosing or managing heart disease?
So that's a fabulous technology and science forecasting question. I think the AI can play an incredibly positive role that when it really complements what humans can do by addressing things that humans cannot do. And specifically, we now know of a wealth of information that's produced, for example, by so-called high-throughput molecular assays that measure, say, all the genes in the body, in a biopsy or circulation or other compartments of the body. They can measure all the mutations or polymorphisms, meaning the genetic variation of inherited genetic material, our DNA that we carry in our cells. They can measure the protein levels across all proteins, the metabolite levels, and so forth and so on. So we're talking about, and in some cases, they can do it on a single cell basis. So now we have data sets that have 50 million variables, for example, per patient. Why? Because we get samples and we measure, say, 5 to 10,000 cells, and for each one of them, we measure tens of thousands of variables per molecular species, genes, proteins, metabolites, and so forth. So we're talking about dimensional spaces that are completely beyond the ability of the human brain to process. And that's one example where AI can be immensely powerful because it can really partner with the human mind, address the areas where the human mind is not very strong, and make it so that the partnership between the human clinician and the machine makes the team stronger. So these are, I think, the areas where clinical AI will thrive and will show immense value. Believing that it's a good idea to replace entirely the human clinician who has empathy, who has fluidity of thought, who has a whole bunch of inference and reasoning abilities that current technology will not reach for many, many, many years, is, I think, a complete fantasy and an oversell of where technology is and about to be in the foreseeable future. But the benefits, I think, are going to be tremendous along the lines I described.
Okay, wonderful. Now, there are many other questions, and unfortunately, we are at the end of the session today. We thank you all to all the panelists for your time and sharing your insights and expertise on the evolution of electronic heart devices, the latest advancements in AI, and also heart transplantation. Most importantly, we would like to thank everyone, our participants in the Mini Medical School, for joining us for this 3-week series. Have a good evening, everyone, and we hope to see you again soon. Thank you. Bye-bye.